So can you go to the next slide? Hi, can you hear me? Hello? Hi, can you hear me?
Yes.
Doctor,
Okay.
you are audible.
Okay, sorry about that. And can you put I've lost, there we go. Can you put to the next slide? And there we go. And then the next slide. Next, there, yeah, okay. So I want to talk about using progenitor cells, stem cells to treat hearing loss in children. And I want to start with an early experience that we had in Houston when I worked there. The idea was that stem cells might help stop the overly aggressive immune response to injury. And so people, and me included, initially thought that when we talked about stem cells that you were putting the stem cell in and the stem cell would then immediately go and become whatever was missing. So, you could replace heart cells, or you could replace liver cells with stem cells. And based on what I'm going to explain to you, we found that actually there's another pathway that these cells can act through, which is to reduce the adverse effects of an overly aggressive immune response, and then also possibly unmask repair machinery that's poorly understood. We do know for sure that stem and progenitor cell therapy is profoundly immunomodulatory. Go to the next slide, please. Next slide, please. Okay, so, oh, sorry, could you go back one slide? Just one. There we go. So we did a trial in Houston treating, we'll go back one slide. We were treating acute severe traumatic brain injury in children. And what we did was, as these children came through the emergency room, we took them to the ICU and we did a bone marrow aspiration, isolated the mononuclear fraction, and then gave it back to them within 48 hours of injury. And typically after head injury, what you see is that over the year after the injury, you'll lose about 10 to 12% of total brain parenchymal volume. And to our great surprise and great pleasure, we found in our patients that they didn't lose brain volume. So what you see here is gray matter is GM, white matter is WM, CSF space is listed, and an intracranial brain volume is listed in the fourth column. And at the time of injury and 6 months later, they maintained brain parenchymal volume. And we believe that this is due to dialing down of the intensity of the immune response after injury that allowed the brain to be preserved. So my wife, who's very interested in hearing loss, said, well, could we possibly use this in a hearing loss scenario? So we did. Next slide, please. Next slide, please. Here we go. So there's a group in Italy that have done really phenomenal preclinical work. It's Revatella, Bettini, and Franceschini. And if you don't know their work, I encourage you to find it. But what they did was to treat mice with kanamycin and then follow that treatment with, oh, can you go back one more slide? We're missing one slide here. So go back one slide, please.
Your voice is not audible, Dr. James. You are muted.
Okay, can you hear me? Can you hear me now?
Yes, yes. Now you
Sorry.
can.
All right, so could you go back one slide? So anyway, so what, there we go. And what you can see is that in these panels that there's been repair of the support cell layer and the hair cell layer. And these improvements were seen at about 30 days from the treatment. So what you can see is that the cochlear morphology has returned to some very similar structure to that was seen in the control pre-treatment. Can you go to the next slide? Okay, can you go to the next slide? Okay. So they then look to see. I'm getting a lot of feedback. Yeah.
Yeah, there was an
There we go.
there was a noise.
Okay, how's that? All right, so they stained the cochlea of these treated animals with anti-human antibodies, and what they found was that the hair cells did not contain human DNA. So the hair cells were not of human origin, not of progenitor cell origin, but they came from the mouse. But they did find cells that contained both human and mouse DNA in the support cell layer. And so they argued from that evidence that the stem cells interacted with the cochlear structure to allow for repair, but did not actually do the repair themselves. So based on this data, we decided to do a human trial. So next slide, please. So we treated 11 children with less than 18 months history of sensorineural hearing loss with intravenously administered autologous umbilical cord blood. And you can see the patient enrollment and treatment timeline and the references in the bottom right corner. So we screened these children to make sure that this was not genetic, this was acquired. And then they came to Orlando, underwent some baseline testing, which included MRI, speech, and audiology testing, and they received their cord blood IV. They were observed overnight, sent home. They came back at 1 month, at 6 months, and at 12 months for repeat testing. They underwent the repeat audiology testing at each visit, the speech testing at 6 and 12 months, and the MRI at the end of treatment. Can you go to the next slide, please? Next slide, please. Okay. There were no adverse events, there were no deaths. A statistically significant reduction in ABR thresholds was identified across the treatment population, and 5 of the subjects experienced a reduction in ABR threshold. When present, the ABR reduction was present at 1 month follow-up, just like the 30 days for Bettini and Rivotella and Franceschini's animal experiments. And the reduction in ABR threshold was durable throughout the 12-month trial. Next slide, please. Dose response considerations. All the subjects who responded received at least 15 million cord blood cells per kilogram of patient weight. There was a trend towards improvement in the conduction velocity of wave 5 of should be cranial nerve 8 in 4 to 5 subjects who experienced a reduction in ABR threshold. So there's a representative patient data for the latency at the bottom, and on the right is just a summary of age and response. Next slide, please. Then finally, there was a suggestion, again, not statistically significant, of improvement of the integrity of the white matter tracts of the auditory pathway. So you can see it's the responders are blue, the non-responders are orange. And you can see pre and post that there's an improvement in this fractional anisotropy, which is an MRI measure of white matter tract integrity. And this was most profound, again, not statistically significant in Heschel's gyrus. Next slide, please. So our phase 1 data, we believe, suggested that cord blood progenitor cell therapy can repair a postmitotic cochlea, improve eighth cranial nerve function, and repair the white matter tracts of the auditory pathways, which we thought was exciting, although very preliminary. And now we are planning a phase 2 trial. We're going to submit for that early next year. Next slide, please. So we're going to this time try to enroll them as soon as they're identified. For the phase 1 trial, we didn't feel it was justified to be aggressive in recruitment because we really didn't know if it would help. But if we are successful, this will be good for 2 reasons. It will result in patients who've experienced shorter periods of sound deprivation, and also allow us to push the dosing higher because the cord blood unit has a fixed number of cells in it. And if the child weighs less, then the dosing will be higher. And so if we can get them younger, that's the goal. And the FDA last time around said that they felt this was very safe and they gave us a license to treat at 6 weeks. So we're hoping that we'll get that kind of a license this time. And then because it's very difficult to enroll children in studies with randomization to non-treatment, we plan to use a crossover design. We'll treat and sham treat at initiation, crossover at 3 months, and treat and sham treat in reverse. And then we'll complete the study at 6 months. And we're going to do basically the same measures we did last time. Next slide, please. We also have much better software to do the MRI DTI interpretation. We're also interested in understanding how specifically the immune response is modified in these patients. With this regimen, so we're going to measure markers before and after treatment. And we would like to get everybody finished with treatment by 9 months, because if it's not sufficiently successful, we don't want them to miss out on cochlear implantation on time. Next slide, please. So these are my co-investigators. Of course, my wife was the person who pushed the idea, and I'm very pleased to have been able to work in hearing loss. Ernest Moore is an emeritus professor at the University of North Texas, who's been very encouraging. Dr. Shook's HEMONC person who oversaw cell infusion. Dr. Messina did the imaging work. Mary Claire Day was a research nurse who was absolutely critical, as was Jennifer Green. And Dr. Nandy did the biostatistics. And Dr. Seidman's a very senior otorhinolaryngologist who moved to Orlando during the study and was very helpful. And I'm happy to take questions now if you have any.
Thank you very much, Dr. James, for the wonderful presentation. Are there any questions for Dr. James?